Okay, so starting with respiratory, first I will start with pneumonias, the treatment, the types of pneumonias, and then COPD, and then ventilation. So this way I will go. We'll try to finish within 2 to 3 sessions. So pneumonias, like as you can see, this is a normal alveolus, and pneumonia is an infection of the lung parenchyma, and this is accumulation of pus in the alveolus. So this is how what exactly happens in pneumonia. Okay, so always remember that full filling of the alveolus, full filling of the alveoli, it causes consolidation. It causes consolidation, as you can see in this picture, and partial filling of the alveolus, whatever may be, it may be fluid or whatever, it causes ground glass appearance. Okay, so full filling of the alveolus causes consolidation, and partial filling of the alveoli causes ground glass appearance. Okay, so we have types of pneumonia. So we have lobar pneumonia, which affects a section of the lobe, a section of a lung, and we have bronchopneumonia, which affects the patches. Okay, so this is lobar, and this is bronchopneumonia. Okay, involves the patches. So in lobar, there is consolidation of the entire lobe, and mainly caused by pneumococcus. And in bronchopneumonia, there is patchy consolidation in the lobes of the lungs, and it is usually bilateral. Bronchopneumonia is usually bilateral, and generally it is basal, mainly involve the lower lobes. Okay, so because of the gravitation of the secretions, the involvement is mainly in the lower lobes. Okay, and it also occurs in extremes of age, like older patients or infants. Bronchopneumonia mainly occurs in extremes of age, like older patients and in infants. Okay, we have older patients and infants. Okay, so these are the signs and symptoms of pneumonia. So patient will come with how will the patient present to you? The patient will have, we have typical and atypical pneumonia. I will come to that. So the patient will come to you with high fever, chills and rigors. Okay, the shortness of breath, dyspnea. Why? Because there is presence of fluid. So there won't be any gas exchange. So anything happens to the lungs, there is dyspnea. Okay, and also tachypnea will occur. So chest pain is typical of in case of typical pneumonia. Cyanosis is a late finding. Cyanosis occurs when there is accumulation of 5 grams of deoxygenated blood. Okay, so it's always a late finding. And fatigue, nausea, vomiting, or diarrhea, these are also non-specific symptoms. Cough mainly.
Hey, Dr. Debate,
Okay.
could you just go back one slide because I accidentally.
So as you can see, this is we have typical and atypical pneumonias. Okay, mainly caused by pneumococcus, which is the most common, and also H influenza. Moraxella can also cause an atypical. We have mycoplasma, legionella, chlamydia, and viral pneumonia. Okay, so the patient will have high fever with chills. As I said, productive cough with the sputum production, and there is chest pain. And there are signs of consolidation like decreased chest wall movement, dullness to percussion, increased vocal firmitus. So this is characteristic. I will come to that. Increased vocal firmitus, agophony, bronchial breath sounds and crepitations. I will come to these things. Okay, leukocytosis, labs will show. So the patient will come to you with these findings, like I have high fever and I have chest pain and I have cough and it produces a sputum. Okay, yellowish sputum or greenish sputum. So what is the first thing you will do? What is the first thing you will do? You'll go for chest X-ray. So in case of pneumonia, we will go for always, the first thing is always we will go for chest X-ray, and chest X-ray will show patchy consolidation or there is lobar consolidation depending upon the type of pneumonia. Okay. So chest X-ray will show patchy or lobar infiltrates, and in atypical pneumonia, non-lobar infiltrates. Okay, present bilaterally. and WBC count may be slightly raised in case of atypical pneumonia, but in typical pneumonia, it's there is leukocytosis, it is always present. Okay. So, in case of atypical pneumonia, the patient will have like slight fever, and the patient will have dry cough, and also myalgia, arthralgia, headache, nausea, vomiting, and diarrhea. These are non-specific features, okay, seen in Legionella pneumonia and other pneumonias. The patient won't be having chest pain. Means chest pain and productive cough are less prominent in case of atypical pneumonia. This thing is important. Okay, in typical pneumonia, the patient will have high fever, chest pain, dyspnea, and also productive sputum. The patient here will be have just chest pain. Means the chest pain will not be there in atypical pneumonia. So the patient will have a mild fever, dyspnea will be there, and no chest pain and dry cough. Okay, so this is a atypical pneumonia, and the causes are these are the causes. Okay. So I said we will go for chest X-ray. Will you be doing for blood culture or sputum culture? So this thing also is important. Like we do not. I mean, generally in case of pneumonia, we treat the patient in the outpatient department. We do not admit the patient. Indications of admission are curve 65. I'll come to that. Okay, so these like if these criteria are not met for hospitalization, we will not admit the patient. So if we don't admit the patient, just we will go for chest X-ray and we will start treating the patient. Okay, with the antibiotics. Okay, we will not go for blood culture. Any case of fever, we generally go for blood culture. Either it is pyelonephritis, high fever, it is pyelonephritis. We are admitting the patient. We go for blood culture. Patient has infective endocarditis. We will go for blood culture. Patient has pneumonia. We admit the patient. We will go for blood culture. Okay. So fever, and we are admitting the patient in the ward. Generally, wherever in the ward or the ICU, generally we go for blood culture. Okay. But here in pneumonia, since we are treating the patient in the outpatient department, so we will not go for any blood culture. We just take X-ray and we start treating the patient. And if the patient meets the criteria of hospitalization, then we will go for blood culture and sputum culture. Then these things will be done. Okay. So for now, being just remember, like we take the X-ray and start treating the patient. Okay. So these are the causes of atypical pneumonia, like various Coxiella burnetii, chlamydia, bacteria, various Legionella, Francisella, Yersinia pestis, Bacillus anthracis, fungus, Histoplasma blastomyces, coccidioides. Okay, these are various causes of atypical pneumonia. And here are the causes. So we have community acquired pneumonia. So we are doing community acquired pneumonia. So it is divided into like community acquired pneumonia. It is divided into typical and atypical. Typical and atypical. Okay. So and we have other types of pneumonia also, nosocomial, which we get from the hospitalization. Okay. Or there are like we have hospital acquired pneumonias. Okay, so in that case pseudomonas comes, it is the most common, and also methicillin resistant staph aureus. So these are the most common organisms in hospital acquired pneumonia. Okay, so these pseudomonas does not come in community acquired pneumonia. Okay, as you can see in community acquired pneumonia we have typical and atypical pneumococcus, H influenza, moraxella. These are the typical. Okay, and we have mycoplasma, legionella, chlamydia. These are atypical. Okay, so but pseudomonas does not come in the community acquired pneumonia. Okay, and this is just like hospital acquired infection. So we have various causes of depending upon the underlying infections. We have various causes of pneumonia, like in case of intravenous drug abusers, staph aureus and oral anaerobes is the main cause. Okay, so staph aureus, it mainly lives on the skin. So if the patient is an intravenous drug abuser, so staph aureus can get into the veins and it can travel to the heart. Okay, and the lungs and cause infection. So intravenous drug abuser, we have staph aureus and oral anaerobes. And if the patient has altered mental status, if the patient is alcoholic, or the patient has neuromuscular disease, so in that case, we will have oral anaerobes. They are the main cause, because if the patient is alcoholic, or the patient has neuromuscular disease like Parkinsonism or myasthenia gravis, or the patient has ALS, amyotrophic lateral sclerosis, so the patient will not be, there is respiratory paralysis suppose, so the patient will not be able to breathe fully. Okay, so that can lead to aspiration, and aspiration of oral secretions. Okay, so oral anaerobes, they are the main cause of pneumonia if the patient is as altered mental status, or if the patient is alcoholic. Okay, patient cannot swallow, patient has impaired epiglottic reflex. Okay, I will come to that. Okay, in that case, oral anaerobes, they are the main cause. Okay, and if there is cavity formation, in that case also we have oral anaerobes. Alcoholic patient, the main cause, if you are asked patient is alcoholic, what is the main cause of pneumonia? It's pneumococcus. Patient is HIV positive, what is the main cause of pneumonia? It is pneumococcus. Do not pick up pneumocystis carinii, pneumocystis, or pneumocystis jirovecii. Okay, an alcoholic patient, do not pick up Klebsiella. The most common cause is pneumococcus. Okay, even in HIV positive patient, what is the most common cause of pneumonia? It is pneumococcus. Okay, Streptococcus pneumonia. Okay, if the patient has cystic fibrosis, as we know, it's Pseudomonas, and if the patient has COPD, then it's pneumococcus, Moraxella, and Klebsiella. Okay, and in case of farm animals like parturient animals, patient is the animal is giving birth, so in that case it's Coxella burnetii, which causes Q fever. Okay, so these are the various causes given in the notes. Okay, clear? Any questions? So these are the further definitions, like we have community acquired pneumonia, which is so the infection gets from the community. Okay, and we have hospital healthcare associated pneumonia during hospital or ICU admission. Okay, so these are the risk factors you may or may not remember: hemodialysis, antibiotic therapy, residence in a nursing home. Okay, these things are not important. So healthcare associated pneumonia mainly it occurs 48 hours after admission. Okay, this thing you have to remember. Nursing home associated pneumonia, hospital acquired pneumonia, ventilator associated pneumonia. Okay, so all of these have the same criteria, occurring typically 48 hours after a hospital admission. This is hospital acquired pneumonia. Nursing home acquired pneumonia during residence in nursing home. Okay, ventilator associated pneumonia, like the patient comes with acute respiratory failure, so we intubate the patient. Patient has COPD attack, we intubate the patient, and after 48 hours we see we do x-ray suppose, and we an x-ray and on x-ray we find new patchy infiltrates, new infiltrates on the x-ray, which were not present initially during admission. Like the patient is a COPD patient, he is your patient in the last so many months, and once he comes to the emergency with acute COPD attack, you do x-ray, you don't find anything positive, and so the patient, since the patient has acute respiratory failure, you intubate the patient, and after 2 to 3 days again you do x-ray, and you find new patchy new infiltrates on x-ray. So that's a ventilator associated pneumonia, typically occurs 48 hours after intubation. Okay, and the main cause is Staph aureus and Pseudomonas. Okay, I will come to that. Okay, so basically Staph aureus and Pseudomonas. Okay, so this is the further definition which I just told. Alcoholism, typical community acquired pneumonia. Okay, COPD, smoking, Pseudomonas, and H influenza. Lung abscess, we have generally oral anaerobes or community acquired. Just you can have an idea. HIV positive patient, influenza patient, also we have pneumococcus and Staph aureus. Whooping cough patient has Bordetella pertussis. Just have an idea. Like, okay, rest everything is given in the notes. Okay, so next we come to criteria for hospitalization. So as I said, it's curve 65. So confusion, high burn creatinine, urea is high, the kidneys are not performing the function. respiratory rate is high, more than 30 per minute, blood pressure is less, systolic less than 90 or diastolic less than 60, or age 65 years. Okay, so if the patient has score of 2 or so, we give 1 point for each of these. Okay, so if the patient has score of 2 or more than 2, then we have to hospitalize the patient. Okay, and if the patient has higher score, if like 4 or 5 score, okay, then we will go for just we will go for ICU admission. Okay, also if the patient is immunocompromised, like the patient is HIV positive, or if the patient has some comorbid conditions like diabetes mellitus or COPD, or the patient has a respiratory distress syndrome, okay, in those conditions also we will hospitalize the patient. So these are not the only criteria. If the patient has comorbid conditions also, then also we will hospitalize the patient. Okay, so the patient, we admit the patient, and the patient has hospital community acquired pneumonia. Okay, and if the patient is producing rusty sputum, so that's characteristic of pneumococcus. And if the patient has like greenish pus, then it's characteristic of Pseudomonas. Okay, so rusty sputum, it's pneumococcus. It's simple. It's and greenish pus, that's for Pseudomonas. Okay, clear? Any question up till now? Simple. Okay, so like whether we admit the patient or we not, means, or we do not admit the patient, we have to give the patient antibiotics. Okay, so if we do not admit the patient, we just, as I said earlier, we just take a chest X-ray and we start treating the patient with antibiotics. Okay, and if we admit the patient, like the patient has comorbid conditions, then we will take blood culture, we'll go for sputum culture, we take, of course, we'll go for X-ray, and then we start the empiric treatment. Okay, so what is the empiric treatment for pneumonia? If the patient is healthy, like and any patient comes to you and he has not used antibiotics in the past 3 months, then we will use macrolides, respiratory macrolides, which is azithromycin or clarithromycin. Okay, this is also, you can have a look at this table also, means rest everything is mentioned in the notes. So if the patient is healthy and there is no use of antibiotics in the past 3 months, then we will use azithromycin or clarithromycin. Respiratory macrolides, azithro or clarithromycin. Erythromycin, it is not used because it does not cover H influenza. So we will not use erythromycin. Okay, it is not used. Okay, because it does not cover H influenza. So mainly these are the respiratory macrolides. If the patient is healthy and the patient has not used antibiotics in the past 3 months. But if the patient is like has used antibiotics in the past 6 months, or the patient has comorbid conditions like the patient has COPD or diabetes mellitus, or like the patient is more than 65 years of age, or the patient has been exposed to a child in daycare center, okay, then what we will do is we will use a combination of respiratory quinolones. We will give the patient respiratory quinolones like levofloxacin, moxifloxacin. These are the respiratory quinolones. Don't remember the doses. Doses will not be asked in step 2 and even for step 3. So these are the respiratory quinolones. If the patient has used antibiotics in the past 3 months, or the patient is older, or the patient has comorbid conditions, or the patient has been exposed to a child in daycare center, so then we use respiratory quinolones. Levofloxacin, moxifloxacin, Gemiflox. Gemiflox can also be given. or we can use, so either respiratory quinolones or combination of beta-lactam antibiotics plus macrolides. Okay, beta-lactam antibiotics are like ceftriaxone, cefotaxime, okay, plus macrolides like azithromycin or clarithromycin. Okay, doxycycline can also be used. Okay, so you can remember for step 2 and even for step 3. So like either we use respiratory quinolones or we use combination of beta-lactam antibiotics plus macrolides, azithromycin or clarithromycin. Okay. So levoflox, moxiflox, gemiflox, these are the respiratory quinolones. We will not use ciplox. Ciprofloxacin it is not used because it will not cover everything. It mainly covers gram-negative. So ciprofloxacin it is for pseudomonas basically because it covers gram-negative. Okay. And we have other anti-pseudomonas antibiotics like we have ipiprocin, tazobactam, imipenem, meropenem, cefepime, ceftazidime. Okay. These are all cover pseudomonas. These are very important. Anti-pseudomonas antibiotics are very important. These are broad spectrum. Okay. So, okay, so we admit the, suppose the patient is more than 65. So we'll admit the patient to the ward, okay, and we will start, we will take X-ray, we'll go for sputum culture, blood culture, and we start giving the patient antibiotics. Like suppose we give a combination of ceftriaxone plus azithromycin. Okay, this combination we are using. So, so we start giving the patient antibiotics, and so the fever should come down within 2 to 3 days. So this is also important. Whatever treatment we are giving, suppose we are treating the patient of infective endocarditis, or we are treating a patient of pyelonephritis. Here we are treating a patient of pneumonia. So fever should come down within 2 to 3 days because we are giving antipyretics also, and we are giving antibiotics. But if the fever does not come down after 2 to 3 days, then we have to investigate. We will go for CT scan to rule out any obstruction because obstruction can lead to stasis of secretion. The secretions will not be able to move and the patient may predispose to infection. Okay, so this is also important. Okay, okay, like so patient comes to us, we do chest x-ray or the patient, we admit the patient in the ward. Okay, so first step is always physical examination, like what are the physical examination findings. So this thing I told earlier also, in case of pneumonia, like so there will be consolidation. Okay, chest x-ray will show patches of consolidation. I will show the chest x-rays. Okay, so when you examine the patient, there will be dullness to percussion on examination. Okay, and also the patient will have bronchial breathing, like the patient will have louder expiratory phase as opposed to normal vesicular breathing. So consolidation means dullness to percussion. Bronchial breathing will be there. So whenever there is bronchial, so we have bronchial breathing and vesicular breathing. Vesicular breathing is normal breathing. In case of vesicular breathing, we have like the expiratory phase, it is silent or it is very small in vesicular breathing. But in case of bronchial breathing, so bronchial breathing will be seen in case of this pneumonia. So in case of bronchial breathing, we will have louder expiratory phase, very loud expiratory phase as opposed to normal vesicular breathing. Okay. So whenever you see louder expiratory phase like this, okay, so that means the patient has bronchial breathing. Okay. And this is mainly seen in consolidation. Also agophony, like the patient says A, and we will hear it with stethoscope, it will be heard as E. Okay, so that's agophony. Vocal fermitus will be increased. We examine the patient, we ask the patient to say 1 to 3, and we hear it with stethoscope, and with the stethoscope it will be heard louder. So whenever you see increased vocal fermitus, so that is seen only in case of consolidation. Patient has pneumothorax or the patient has pleural effusion, presence of fluid in the pleural cavity. So that will cause decreased vocal firmness. Okay. So increased vocal firmness, it is always seen in case of pneumonia consolidation. Whenever you see, like these are key points. If you see a long question, you see one of the points mentions the vocal firmness, it is increased. Okay. So that means the patient has consolidation. Okay. And if the patient has, of course, pleural effusion, we will have dullness to percussion, decreased breath sounds, and the chest fall movement will be decreased, and also decreased vocal firmness. In case of pneumothorax, we will have resonance to percussion, decreased breath sounds, and also decreased vocal firmness. Okay, so in pneumothorax, we will have resonance to percussion, and pleural effusion, we will have dullness to percussion. Okay, simple things. Now there is something called post-influenza pneumonia. Like I discussed the various causes of pneumonia, so we have post-influenza pneumonia. So it's mainly caused by Staph aureus and pneumococcus. So the patient comes to you with myalgia, arthralgia, patient has mild fever, okay, and so how will you treat the patient? Like so you tell the patient it's just mild flu. You go back home, okay, and it will means it will be you will be okay within few days. So after few days, the patient comes to you that what kind of doctor are you? My fever is very high now. I have chills. I'm coughing very badly. I have production of sputum, very high amount of sputum. So that means the patient has developed pneumonia, and the main cause is pneumococcus or Staph aureus. Okay, so in that case, you will give the patient combination. So I told, means the treatment of pneumonia, it's like we give the patient combination of ceftriaxone plus azithromycin generally, or we give the patient respiratory like levofloxacin, gemifloxacin, moxifloxacin. So suppose we started the treatment with ceftriaxone plus azithromycin. So since another cause of post-influenza pneumonia can be Staph aureus, so we have to cover Staph aureus also. So we give the patient vancomycin. Okay. Okay, so in post-influenza pneumonia, this is our treatment. Okay, either we give levofloxacin, moxifloxacin plus vanco, or we give the patient combination of ceftriaxone plus azithromycin, which will cover these bacteria. But for covering Staph aureus, we have to give the patient vancomycin. And there are other anti-staph antibiotics. What are those? Like we have linezolid, daptomycin, tigecycline, and also ceftaroline. So these are the anti-staph antibiotics. Okay, daptomycin, linezolid, ceftaroline, and tigecycline. If the patient has vancomycin allergy, okay, in that condition, what are the side effects of vancomycin? What are the side effects of vancomycin? So vancomycin can cause ototoxicity, nephrotoxicity, and also Redman syndrome. There will be reddish rash. Okay. So this is for post-influenza pneumonia. Patient can have another is a Friedlander's pneumonia, which is Klebsiella pneumonia. So it occurs mainly in alcoholics, and the patient will have mucoid colonies and current jelly sputum. Current jelly sputum. Okay. So current jelly sputum, it is seen in case of Friedlander's pneumonia, Klebsiella pneumonia. Current jelly stool, it is seen in case which condition? Intussusception. In advanced cases of intussusception, okay, not in earlier stages. Patient generally the child will have severe abdominal pain and altered mental status, okay. And if there is ischemia, that will lead to reddish stools, which we call as current jelly stools, okay. So current jelly sputum in Klebsiella pneumonia, current jelly stools in very advanced cases of intussusception, okay. Okay, next we come to atypical pneumonias. So these were typical pneumonias. Next we come to atypical pneumonia. So we have mycoplasma pneumonia, chlamydia, legionella, Q fever. Okay. So mycoplasma, it mainly occurs in younger college-going adults, especially adolescent, and it causes peribronchial and perihilar infiltrates. Okay, I will show you the X-rays. Peribronchial and perihilar infiltrates. Also, the patient will have erythema multiforme. So erythema multiforme is mainly caused by. So we have like a spectrum, erythema multiforme. Then we have Stevens-Johnson syndrome. Then we have toxic epidermal necrolysis, as we know from dermatology. So erythema multiforme will have target shaped lesions, and mainly it is caused. So M for multiforme, M for mycoplasma infection. Okay, so mainly it is caused by infection, and also herpes simplex infection that can lead to erythema multiforme. Stevens-Johnson syndrome and toxic epidermal necrolysis, they are not caused by infection; they are drug reactions. Erythema multiforme can also occur because of drug intake, but mainly it is caused by infection. Stevens-Johnson syndrome and toxic and TEN, they occur mainly by drug reactions. Okay. So, mycoplasma pneumonia patient will have these peribronchial, perihilar infiltrates. Erythema multiforme will be there. Uh, Peribronchial or perihilar infiltrates. Okay. And also the patient will have like bullous meningitis, like inflammation of the tympanic membrane, and there will be presence of vesicles in the tympanic membrane. This is also characteristic. Bullous meningitis. So presence of vesicles on the tympanic membrane, and also on the external auditory canal. Scratchy sore throat, tracheal tenderness. This is also characteristic. Tracheal tenderness is characteristic of mycoplasma. Okay, so these are very important points. Okay, patient may have headache, dry cough. So this is because it's an atypical pneumonia, fever. These are non-specific findings. Okay, so you have to remember erythema multiforme, bullous meningitis, peribronchial and perihilar infiltrates, scratchy sore throat, and tracheal tenderness. These are characteristic. Tracheal tenderness, it is also can be seen in epiglottitis also. In case of croup also we can have tracheal tenderness. Okay. So diagnosis is for mycoplasma will not go for a gram stain, we will go for serological test. Okay, because it lacks cell wall. So that's for mycoplasma pneumonia. Treatment is same, antibiotics like we can give macrolides, or generally we give quinolones, respiratory quinolones like levofloxacin, gemifloxacin, or moxifloxacin. Okay, so that's for mycoplasma pneumonia. Next, we have legionella pneumonia. This is also very important. So it mainly occurs by cooling system, air conditioners. Okay, so the cooling system of the building or of the hospital or whatever it is. Okay. So in case of legionella pneumonia, we will have temperature pulse dissociation. Like the patient will have high temperature with bradycardia. So whenever you see high temperature with bradycardia, temperature pulse dissociation, and also the patient will have altered mental status and diarrhea. So it is mainly legionella pneumonia. These points are characteristic. The patient will have altered mental status, AMS. Why this occurs? Because of hyponatremia. Because of hyponatremia. And why this hyponatremia occurs? Because the patient develops SIADH. Okay. So always remember, any neurological abnormality, any brain abnormality, like the patient has like patient has stroke, or the patient has subarachnoid hemorrhage, or intracerebral hemorrhage, or the patient has tumor in the brain, whatever, it can lead to SIADH. Okay, any lung abnormality, like the patient has pneumonia, or the patient has acute respiratory failure, patient has severe COPD attack, it can lead to SIADH. Okay, patient has pneumonia, it can lead, or cancer, small cell lung cancer specifically, it can lead to SIADH. So any neurological abnormality or any lung abnormality can lead to SAEDH. Okay, so the main so the pneumonia which causes SAEDH, mainly it is Legionella pneumonia. Okay, what are the other causes of SAEDH? So we have drugs which causes SAEDH, like we have 3Cs like carbamazepine, clofenac, and also the patient has a cyclophosphamide and also chloropropamide. So 4C, sorry, 4Cs. Okay, so these are the drugs which cause pneumonia: chloropropamide, cyclophosphamide, carbamazepine, and clofenac. Okay, SSRIs, TCA, they can also cause SAEDH. Okay, SSRI, TCA, they can also cause SAEDH. Okay, so mainly in case of pneumonia, it's Legionella pneumonia, so that causes SAEDH. So the patient will have hyponatremia, and that will lead to mental confusion, altered mental status. Vomiting and diarrhea will occur, and generally temperature pulse dissociation. So these are the main three characteristics. Okay, and the diagnosis will be Legionella antigen in the urine. Antigen in the urine, and treatment is quinolones or macrolides. So that's for Legionella pneumonia. Next we have chlamydia pneumonia. So chlamydia pneumonia, it mainly occurs in vets like poultry farmers or bird raisers, and there is a triad of meningoencephalitis, splenomegaly, and pneumonia. So we are discussing pneumonia. So the patient will have pneumonia plus meningoencephalitis, and also the patient will have splenomegaly. So that's chlamydia pneumonia. And diagnosis will be again serological test, and we will give the patient macrolides. Okay, for chlamydia. Doxycycline can also be given. So chlamydia pneumonia, we have meningoencephalitis, splenomegaly, and pneumonia. In case of Q fever mainly occurs because like when you are exposed to secretions of pregnant animals. Okay, so in Q fever also we have pneumonia plus meningoencephalitis and hepatitis. Okay, so this way you can remember. Clear? Diagnosis again serological test. Okay, so in all these cases we will going for serological test. In Legionella pneumonia, Legionella antigen in the urine. Okay, clear? So these are the typical and atypical pneumonias. Any questions? So this is the treatment which I just covered. And Francisella tularensis, it causes tularemia. It mainly the patient is exposed to rabbits. Patient will have pneumonia, can lead to altered mental status, and also the patient will have skin lesions with black scar in case of tularensis. Okay, clear? So we have recurrent pneumonia, persistent pneumonia. So persistent pneumonia, like the patient fails to heal after 2 weeks of therapy. Like we do chest X-ray, and on chest X-ray, if you find like we start treating the patient, so the symptoms will decline. The patient will be fever will decline, and cough and chest pain will be okay within a few days. Okay, so the X-ray findings will remain there. So the X-ray will remain positive for 1 or 2 months. So like the features, the patches which we see on X-ray, they will, so X-ray will be free from those consolidation patches, whatever we see on X-ray after 1 or 2 months. Okay. So if the patient, like if there is no resolution of symptoms, like the patient fails to heal, patient has high fever up till now, and also the patient has a fever, a cough with chills, and there is a sputum, means after even 2 weeks of therapy, then we call it as persistent pneumonia. Persistent pneumonia, okay. And we have recurrent pneumonia, like pneumonia. So the patient is completely okay now. We started the patient on treatment, 10 days of therapy generally, 7 to 10 days of therapy, and the patient is okay now. And on X-rays also means we will see resolution of the patches. Okay, but again the patient starts having features of pneumonia. Okay, so that is recurrent pneumonia. So, but generally we don't see, means it's very, sometimes it becomes difficult to differentiate between recurrent pneumonia and persistent pneumonia. So distinction between these two may not be evident, okay, many times. So there is significant overlap between these two, and demarcation is not evident clinically many times. So pneumonia occurring in the same location again and again, it is recurrent pneumonia. It is also defined as like 2 or more episodes of pneumonia in a single year, 2 or more episodes of pneumonia in a single year, or 3 or more episodes ever with radiographic clearance in between occurrences. Okay, so that's recurrent pneumonia. 2 or more episodes of pneumonia in a single year, or 3 or more episodes ever with radiographic clearance, means that there are no chest X-ray. Chest X-rays turned out to be normal in between occurrences. Okay, so that's recurrent pneumonia. That's yeah, that's recurrent pneumonia. Okay, clear. So the patient has these recurrent pneumonia or persistent pneumonia, whatever, and many times, as I said, you won't be able to differentiate. Okay, so what is the first thing you will do? You will go for chest X-ray. So first step is always chest X-ray, and then we will go for CT scan to rule out any obstruction. And if there is obstruction, like the patient is 65 years of age, and the patient is a smoker, then the cause of obstruction may be some tumor, okay, bronchial carcinoma. But if the patient is younger, then the cause is bronchial carcinoma. This thing also is important. Younger patient, the cause of obstruction is bronchial carcinoid, and in older patients, it is bronchogenic carcinoma. Okay, so the patient has recurrent pneumonia or persistent pneumonia. What is the first thing you will do? Of course, CT scan, of course, chest X-ray. Patient says, I don't have any relief of symptoms, or again, I developed the same symptoms which were developed. Like the patient comes to you in the month of June, suppose, and the patient had pneumonia in the month of January also. So, so the patient has recurrent pneumonia. So the first thing you will do is you will go for chest X-ray, and also to rule out any obstruction, we will go for CT scan. So if the CT scan shows an obstruction in the bronchus, then the next step will be bronchoscopy. Okay. So first chest X-ray. So this is the protocol we will follow. Chest X-ray. You will find a pneumonia patch in the same location. Okay. So that's recurrent pneumonia. So we'll go for CT scan because we want to rule out any obstruction. Patient is a smoker, suppose. So that means like there is obstruction. So by bronchogenic carcinoma, so we'll go for bronchoscopy to take biopsy and also remove the obstruction. Okay. Now, if CT scan shows like CT scan shows a mass in the bronchus, then we'll go for bronchoscopy. We can remove the tumor, we can take biopsy. But if CT scan shows a peripheral lesion, there is lesion in the periphery, then in that case we cannot go for bronchoscopy. Then we go for VATS, video assisted thoracoscopic surgery. Video assisted thoracoscopic surgery. Okay. Or we can go for percutaneous, means if the lesion is the periphery, we can go for percutaneous CT guided biopsy also. CT guided biopsy if the lesion is periphery. So either CT guided biopsy or VATS. So like the lesion is in the periphery, we go for CT scan and we find some tumor in the periphery. In that case, we cannot go for bronchoscopy. We can go for bronchoscopy, so we'll go for CT guided biopsy. Like we go for CT scan and we take the biopsy. Okay, if the biopsy misses, then we go for video assisted thoracoscopic surgery. Okay, we put a probe inside and then we can remove the tumor. Okay. So this is video assisted thoracoscopic surgery. Okay, and we can remove the tumor like this. So it is done when CT guided biopsy it is not successful. Okay, next we come to ventilator associated pneumonia or healthcare associated pneumonia. Okay, so we did this earlier also. So as I said, so healthcare associated pneumonia, it may be like nursing home or hospital acquired pneumonia or ventilator associated pneumonia. So it occurs after hospital admission, 48 hours after hospital admission, healthcare associated pneumonia. Okay, community acquired pneumonia, which we get from the community. Okay, so this hospital acquired pneumonia is defined as pneumonia which occurs 48 hours after admission or within 3 months after discharge from the hospital. Three months after discharge from the hospital. Okay, and it is of various types, as I said. So we have like a ventilator associated pneumonia, which I told just now. Like the patient comes to you with COPD attack, and we intubate the patient, and after 48 hours we see new patches on X-ray, okay, which were not present, and the patient has purulent secretions. Okay, so that is ventilator associated pneumonia, and the main cause is Pseudomonas and also Staph aureus. Okay, so we give the patient in VAP, we will give the patient combination of Venco that will cover Staph aureus, and we will cover and plus ciprofloxacin, imipenem, meropenem, cefepime, ceftazidime, all any of the anti-Pseudomonas antibiotics. Okay, so this is the treatment. In empiric treatment. So these are all empiric treatments. Okay, for VAP. Okay. So how can we prevent VAP, ventilator associated pneumonia? This is also very important. Very important. So like what we do is we raise the patient. We like the if the patient is on ventilator, what we will do is we will raise the head end of the patient. We will keep the patient in a semi-recumbent position. Raise the head end by 45 degrees. Okay, elevate the patient. This is important. Okay. Okay, so this is how we prevent VAP. Also, aspiration pneumonia patient has like myasthenia gravis, or the patient has ALS, whatever the patient has. What we will do is we will raise the head end of the patient so that patient does not aspirate. Okay, this is important. Okay, lung abscess can also be prevented by raising the head end of the patient 45 degrees. This is very important. We can reduce a lot of conditions by just raising the head end of the patient. Okay. Okay, so next we come to aspiration pneumonia. Like the patient is severely alcoholic, or the patient has some neuromuscular disease, like I said, myasthenia gravis or Parkinsonism or ALS. Okay, or the patient has severe dementia. Okay, so in all these cases, there is loss of swallowing reflex. The patient is unable to swallow, decreased swallowing. Patient cannot swallow. Okay, so and also means because of loss of impaired epiglottic function, the patient's epiglottis is unable to be since the patient cannot swallow. So there is impaired epiglottic function. This is a very important point. And because of this, the patient will have aspiration of secretions causing aspiration pneumonia. Okay. So what we will do is we will place the patient in a semi-recumbent position or upright supine position, which will prevent any aspiration of secretion. Okay. That's aspiration pneumonia. There is something called aspiration pneumonitis. Aspiration pneumonitis. So it's just a chemical reaction. Patient has a like ALS, amyotrophic lateral sclerosis, or the patient has myasthenia gravis with acute respiratory failure. Patient cannot swallow, so there will be aspiration of secretions. Okay, so because of so when these secretions get into the lungs, there is some chemical reaction, and this chemical reaction can cause aspiration pneumonitis. And on chest X-ray, we will see infiltrates. So there is difference between aspiration pneumonitis and aspiration pneumonia. So pneumonitis, it's basically a chemical reaction. Okay, and the patient will have cough will be there, chest pain will be there. Okay, and if there is superadded infection, that will cause aspiration pneumonia. Okay, so there is pneumonitis, which is just a chemical reaction, and we have pneumonia, which is superadded infection. Okay. So treatment of aspiration pneumonitis, it's just supportive treatment. Okay, we will not give the patient antibiotics. Treatment of aspiration pneumonitis, it is supportive without any antibiotics. Okay, and treatment of pneumonia, it is we of course will give the patient antibiotics. Okay, mainly antibiotics which cover oral anaerobes. Okay, like ampicillin sulbactam, piperacillin tazobactam. I will come to that. Okay. So the patient will have, in case of aspiration pneumonia, we will have excessive amount of foul smelling sputum, very high amount of foul smelling sputum. So this high amount of foul smelling sputum, it is seen in three conditions. We have aspiration pneumonia, we have lung abscess, and also in case of bronchiectasis. So foul smelling sputum, it is seen in three conditions: aspiration pneumonia, lung abscess, and also bronchiectasis. Okay, I will come to that. Okay. And also fever with high with chills. Okay, and mainly it is caused by mouth anaerobes and also gram negative. So mouth patient cannot swallow, so the cause is anaerobes. Okay, so these are the anaerobes. And also, like, the patient can have another cause can be gram negatives. Okay, because they are present in the intestine. So there is an aspiration of gastric secretions. Okay, so these gram negatives, they are present like E. coli, they are present in the intestine. So these are the main cause. Okay, anaerobes, mouth anaerobes, oral anaerobes, and also gram negatives. Okay, so we give the patient broad spectrum antibiotics. Broad spectrum antibiotics which will cover all these. Okay, so we have piperacillin tazobactam, uh, piperacillin tazobactam, or ampicillin sulbactam. or we can give, so these are broad spectrum antibiotics, or we can give clindamycin also. Clindamycin also covers anaerobes, and the treatment has to be for 4 to 6 weeks. Okay, this 4 to 6 weeks you may or may not remember. Okay, so that's for aspiration pneumonia. Clear? Any questions? So this is the mechanism of aspiration pneumonia, as you can see. Patient has dysphagia, poor cough reflex or aspiration. So GERD can also leads to pneumonia. Okay. So next we come to lung abscess. So this is lung abscess. So the patient has aspiration pneumonia. First, there is a patient cannot swallow. Okay, patient has myasthenia gravis or whatever. Patient cannot swallow. There is aspiration of contents that lead to aspiration pneumonitis, and there is superadded infection leading to aspiration pneumonia. Now, this pneumonia, like this infection, it damages the lung parenchyma. It damages the lung parenchyma, and that leads to formation of a lung abscess. It damages the lung parenchyma, that leads to formation of a lung abscess. Okay, so as we can see, like we have this black tissue. Okay, in the lungs there is and alveoli, there is presence of air in the alveoli. Okay, so whenever there is presence of fluid in the alveoli, that will give rise to air fluid levels. Air fluid level. So this is air fluid level. So this black arrow indicates air fluid level, and these white arrows indicates the areas of consolidation. Okay, so there is significant damage to the lung parenchyma that will lead to formation of, that will lead to consolidation, and a lot of alveoli have been damaged. Okay, and also, so since there is presence of pus in the alveoli, and in the alveoli there is presence of air, so that will give rise to air fluid level. Okay, so the air will be higher in the alveoli, and the pus, the fluid will accumulate in the base. Okay, that will give rise to air fluid level. Okay, nothing difficult to understand. If there is intestinal obstruction, that also will give rise to air fluid level, because there is because of obstruction, the contents are unable to pass through the intestine, and the patient will have same air fluid levels. Okay, so same air fluid levels here also. Okay, in case of lung abscess. So on chest X-ray, we will see this air fluid levels, and the patient will have excessive amount of false sputum and also amphoric breath sounds. So this amphoric breath sounds, these are characteristic in case of lung abscess. Very harsh breath sounds. Okay. So mainly lung abscess occurs on the right side. On the right side, because the right bronchus, it is shorter and more vertical. Okay, and the main locations are PUAL. This way you can remember. This is my mnemonic. You can make your own mnemonic. Okay, so if the patient is standing, then we will have posterior segment of the right upper lobe. Posterior segment of the right upper lobe. But if the patient is recumbent, then it is apical segment of the right lower lobe. Sorry, it's the opposite. If the patient is standing, then it is apical segment of the right lower lobe. Okay, because the secretions will go down. And if the patient is recumbent position, then it is posterior segment of the right upper lobe. Okay, this question can also be asked. So basically step 2 is very simple. It's just the basic concepts you should know. So recumbent position, posterior segment of the right upper lobe, and in standing position, apical segment of the right lower lobe. Lower lobe, why? Because of the gravity, the secretion will settle down. Okay. Okay, so that's for lung abscess. Treatment is again same as we gave in aspiration pneumonia, ampicillin sulbactam, piperacillin tazobactam, clindamycin for 4 to 6 weeks. Okay, clear? So that's for lung abscess. So let's discuss about X-rays. So as you can see, this is a patch of consolidation. This is a case of lobar pneumonia. Okay, so when we take X-rays, so the normally alveoli have air. There is presence of air in the alveoli. Okay, so we will have this black shadows. Okay, and if there is consolidation, that means there is presence of pus in the alveoli. Okay, so that will give rise to a whitish tissue. Okay, but it will not. There won't be any complete whiteout of the lung. There is no complete whiteout of the lung. As you can see, there are black tissues here also. So there is presence of air in the bronchograms. Air in bronchograms. Okay, so because of this air in the bronchograms, it will give rise to some black zones also. Okay, so as you can see, there is some blackish tissue also here and there. That is a means it is a case of pneumonia. Okay, so we will have a chest X-ray will show air, means this kind of picture, air in the alveoli, and wherever there is consolidation, we will have white picture, this like this, and there is presence of blackish tissue in between. So that is because of air in the bronchogram. So this is typical of pneumonia. Okay, now look at this picture. So we have this is a normal lung and we have pneumonia. This is a huge case of pneumonia, means whole of the lung is involved. So as you can see, there is blackish tissue in between. Okay, that is because of presence of air in the alveoli. Okay, so this is a typical case of pneumonia. Okay, in case of pleural effusion, or there is atelectasis, so whenever the lungs are filled with air, we will have black tissue, black X-ray. Okay, but if there is presence of air in the alveoli, sorry, if the alveoli lack air or there is presence of fluid, so that will give rise to whitish tissue. Okay, so in case of pleural effusion, we will have this complete whiteout of the lung, as you can see, and we don't see any black tissue here. There is complete whiteout. Okay, so first these angles are obliterated. This is a costophrenic, this is cardiophrenic angle, and this is costophrenic angle. So whenever there is pleural effusion develops, so first these angles get obliterated. Okay, and then we will have this whitish tissue. Okay, but there is no black tissue in between. Okay, like we saw in this case. Okay, this is a case of pneumonia patch, and this is pleural effusion. Okay, so because of pleural effusion, if there is a huge pleural effusion, the trachea will deviate toward the opposite side. It will deviate toward the opposite side. Okay, this way you can recognize. These X-rays can come in the exam. Okay, so wherever you find that the picture is important, just take screenshots and you can compare it with other pictures, whatever you have, like in Q banks or whatever. Okay, clear? So this is air in the, this is for pleural effusion. We have complete whiteout and trachea deviated toward the opposite side. This is another case. So as you can see, complete whiteout of the lung and trachea deviate toward the opposite side because of there is huge presence of fluid. Generally, if there is mild amount of, means small amount of fluid is present, then these angles get obliterated first. Okay, look at these angles, and they will be, you won't be able to see them clearly. Okay, okay, now pleural effusion give rise to white white out of the lung. Okay, and atelectasis, in which there is collapse of the lung. Okay, like the patient underwent an operation, abdominal hernia operation, and now the patient is in very severe pain. So the patient won't be able to breathe deeply, and also because of hernia repair, there is increase in intra-abdominal contents. Intra-abdominal pressure will increase. Okay, so that will put a lot of pressure here on the chest. So the patient is not breathing deeply. Also, the patient has some morphine injection because of pain. So that will decrease the respiratory rate further. So that can lead to a collapse of the alveoli, causing atelectasis. Okay, so in atelectasis also we will have complete white tissue. Okay, and also the trachea will deviate toward the side of the lesion. So here trachea deviate toward the side. Okay, toward the affected side. Okay, in case of pleural effusion, it was toward the opposite side. Okay, Clear? Any questions? And this is for pneumothorax. So as I said, if there is presence of air, that will give rise to black tissue. Okay, so here we have pneumothorax. So you can see this is a pleural line, and we have this black tissue, excessive amount of blackish tissue. So that's pneumothorax, presence of air in the pleural cavity. And we have this normal lung. So we will have these vascular markings, as you can see. So these markings, they are absent here. They are present here. They are present here, okay, but they are absent here. Okay, so in case of pneumothorax, we will have complete black zone. Okay, it is opposite of what we saw in pleural effusion. Okay, so this is also pneumothorax. This is pneumothorax. Okay, so here we have the blood vessels, and we will have, this is complete black. This is also pneumothorax. Okay, we will have, on examination, we will find resonance to percussion, decreased vocal firmitus. Okay, decreased breath sounds. In case of pleural effusion, we will find dullness to percussion, decreased breath sounds, and also decreased vocal firmitus. Okay, so vocal firmitus will be decreased in both the two cases. Okay. Okay, what is this? Can you tell me? So here the lungs appear black, more black. Okay, so it is because of entrapment of the air in the alveoli. Okay, so this is typical picture of COPD. Okay, so the lungs appear dense, very dense, and there's a lot of air entrapped here. A patient has emphysema. Okay, so there's a lot of air entrapped in the alveoli that will give rise to this dense picture. Okay, so whenever you see this kind of picture, so that is COPD. Also, there is a flattening of the diaphragm. Okay, so you will see like these expanded lungs. Okay, because of the entrapment of the air. I will come to that. Okay, that's a typical case of COPD. Okay, clear? Any questions? Okay, next we come to COPD. So as you can see, we have emphysema, we have chronic bronchitis, we have asthma. Okay, and it's not watertight compartments, means there is significant overlap between the three. Okay, so emphysema and chronic bronchitis, they are irreversible. There is significant damage. I will come to that. Okay, asthma, it is reversible. Okay, so but as you can see, there is significant overlap between the three. Okay, so what means what we see in clinical practice may be combination of all the three. Okay, so we cannot say, okay, as we know, means emphysema is pink puffers and chronic bronchitis is blue bloaters. Okay, but we will not, in clinically we don't see, okay, this is pink puffer and this is blue bloaters. Okay, and we cannot see like this, we cannot say like this. Okay, because there is what we see in clinical practice, in clinically we will see a combination of these two. Okay, and generally we have, in asthma there is a reversible changes, but we may see there can be significant overlap with asthma also. Okay, okay, so the patient comes to you with dyspnea. What is the first thing you will do? So we do not know whether the patient has COPD, which is irreversible, or the patient has asthma. Okay, so first thing we will do is we will go for we will go for spirometry. Okay, so means we will go for pulmonary function test. So pulmonary function test, we have basically 4 pulmonary function test. 4 pulmonary function test, which include we have spirometry, we have diffusion capacity. So first we have spirometry, Second, we have diffusion capacity. Flow volume loops, I will come to that later, and lung volumes. Flow volume loops, and last we have lung volumes. Okay. So lung volumes basically, they like whatever we did in spirometry, because the function of spirometry is to diagnose COPD or asthma or bronchiectasis. Okay, function force expiratory volume or the ratio. Okay, but so lung volumes, they help in confirming the findings on spirometry. Like the patient has a total lung capacity, it is less than 80%, so that indicates the patient has restrictive lung disease. Okay, and patient has decreased vital capacity with increased residual volume. Okay, so these are all lung volumes, so that indicates the patient has obstruction. And this DLCO, it is reduced. So lung volumes basically, they are used to confirm the findings on spirometry. Like we have total lung capacity, which is decreased in case of restrictive lung disease. We have residual volume, and which is increased in case of obstructive lung disease. So these two values, they are increased in case of restrictive lung disease, in case of obstructive lung disease, but they are decreased in case of restrictive lung disease. Okay, DLCO, it is used in patients with emphysema, pulmonary fibrosis, and bronchiectasis. Okay, because of the decreased surface area. Okay. Suppose spirometry is normal. Suppose spirometry is normal. This is normal. And we find decreased DLCO. Can you tell me what can be the cause? Spirometry, it is normal, but we find decreased DLCO, diffusion capacity. So what can be the cause? Pulmonary vascular disease. This point not very important. Spirometry is normal, but we find decreased DLCO. So it is pulmonary vascular disease. Okay. In asthma, DLCO is normal. In bronchitis also DLCO, it is normal. It is not decreased. So I'm asking decreased DLCO. Okay. So it is seen in pulmonary vascular disease. Okay. Okay, so the patient comes with dyspnea. We will go for spirometry, and we find that the FEV FVC ratio, it is decreased. FVC, force expiratory volume, and in 1 second, and FVC, functional vital capacity, it is decreased. The ratio, normal it is 80%. Normal it is 80%, and here in case of COPD, it is around 70%. So that indicates the patient has obstructive lung disease. There is some obstruction, there is some abnormality. Okay, so we want to know what the abnormality is. Okay, so the patient can have either of these three things. Patient can have emphysema, means there is significant overlap, and there is chronic bronchitis, or the patient can have asthma. Okay, but in case of so what we will do, we will, to differentiate between these two, these three, we will go for bronchodilator test. We will go for bronchodilator test. Okay. The patient comes with dyspnea. We did the spirometry and we find the ratio, it is 70%. That means there is some obstruction. Okay. So, but since the patient has dyspnea, we want to know whether it is reversible or irreversible. We'll go for bronchodilator test. Okay. So, bronchodilator test, we give the patient albuterol or terbutaline, and if there is increase in FEV by more than 12%. So, this is on spirometry. So, we find a decreased ratio. It is decreased. Okay. So, next the patient has dyspnea. So, next step is we go for bronchodilator test. We give the patient albuterol or terbutaline, short-acting bronchodilators. And if there is increase in FEV1 by more than 12%, so this thing you have to remember. We give the patient albuterol or terbutaline, and if there is increase in FEV1 by more than 12%, so there, as you can see, there is increase in FEV1 by more than 12%. So this 12% is important. Then it's a case of asthma. Okay. Methacholine challenge test, it is not the same. It is done when the patient comes is normal. Okay, so it is different thing. Okay. I will come to that. Okay, so this is the patient comes to us with dyspnea. We did the spirometry and we find decreased ratio. Okay, so now we have to differentiate whether the patient is asthmatic. So we will go for bronchodilator test because asthma is reversible. Okay, so if there is increase in FEV1 by more than 12%, then it's a case of asthma. Okay. So a post bronchodilator F ratio of less than 70% and FEV1 less than 80% of predicted, it suggests COPD. Okay. Okay. So post bronchodilator FEV1 FVC ratio less than 0.7 and FEV1 less than 80% of predicted, it suggests COPD. Okay. So like there is inflammation in both the cases in COPD and it is irreversible, and asthma it is reversible. So there is inflammation in both the cases, but asthma it is eosinophilic, and airflow inflammation in case of COPD it is neutrophilic. So neutrophils in case of asthma, sorry, neutrophils in case of COPD, and we have eosinophils in case of asthma. Eosinophils, okay. And also, like the cough is nocturnal and generally it is dry. Cough is nocturnal and generally it is dry in case of asthma, and COPD it is mainly daytime productive cough. Okay, it's daytime productive. In case of asthma, it is generally, means it is, as I said, there is significant overlap. So you cannot say this is this and this is that. Okay, so there is significant overlap. So these are the general findings. Okay, so in asthma, it is generally nocturnal and it is dry. Nocturnal cough and dry cough. Okay. So hyperinflation, cor pulmonale, right heart failure, secondary to some lung abnormality, cor pulmonale, chronic hypercapnia. These are more common in COPD. So hyperinflation, cor pulmonale, hypercapnia. It is more common in case of COPD. Okay, but rare in case of asthma. Okay, clear. So this is the further comparison between asthma and COPD. Okay, generally it occurs at young age. Nighttime attacks, this thing I told, dyspnea, dry cough will be there, and COPD patient will have dyspnea and productive cough. Okay, so this is the comparison, but significant overlap is there. Okay. And this is a chronic bronchitis and emphysema. This is emphysema, pink puffers, and we have chronic bronchitis, blue bloater. Okay, I will explain later. So, cor pulmonale, it is more common here in case of chronic bronchitis because there is more hypoxemia. Because there is more hypoxemia. Okay, there is more hypercapnia. Because there is pulmonary vasoconstriction, and this is the characteristic of pulmonary vasculature, that in response to hypoxemia there is vasoconstriction. In response to hypoxemia there is vasoconstriction. Okay, and because of this vasoconstriction, the patient will have high pulmonary vascular resistance. Pulmonary hypertension will be there, and that can lead to cor pulmonale. I will explain later. Okay. This is the comparison between emphysema and bronchitis. So dyspnea, it is very severe here, and bronchitis it is. So how will you define bronchitis? So bronchitis, it is defined as chronic, means it is defined clinically. Chronic productive cough for 3 consecutive months for at least 2 years. Chronic productive cough for 3 consecutive months for at least 2 years. Okay, and that is chronic bronchitis. Emphysema, it is defined histologically, like destruction of airways distal to the terminal bronchioles. Destruction of the airways distal to the terminal bronchioles. So that's emphysema. So as you can see, this is emphysema, destruction of the airways distal to the terminal bronchioles. So beyond the terminal bronchioles, we have alveolar ducts, alveoli, okay, and respiratory bronchioles. So respiratory bronchioles, alveolar ducts, and alveoli, they are damaged in case of emphysema. Okay, so it's defined clinical, histologically. So that's why. So because of decreased surface area, the patient will have decreased DLCO. Okay. Diffusion capacity will be decreased in case of emphysema. In chronic bronchitis, it is normal because as you can see, this is chronic bronchitis. Okay. So in chronic bronchitis, what happens? There is goblet cell hyperplasia causing thick secretions. So that's why the patient has productive cough for at least 3 months. Okay, because of this goblet cell hyperplasia. So the air gets trapped inside. So these are both COPD. So there is means a patient inhales, but the patient will not be able to exhale. So the air will entrap inside. Okay. So because of the entrapment of the air inside, the patient will have increased total lung capacity, increased residual volume. These things are increased in case of obstructive lung disease. Why? Because the air gets entrapped. Okay. Remember the chest X-ray which I showed you. There is hyperinflated chest. Okay. So in case of chronic bronchitis, there is goblet cell hyperplasia. So here pathology lies in the terminal bronchioles. Terminal bronchioles in chronic bronchitis. In emphysema, it is distal to terminal bronchioles. Distal to terminal bronchioles. Okay. Distal to terminal bronchioles. Okay. In the respiratory bronchioles. So as I said, in case of chronic bronchitis, the air will not be able to move out. Okay, so there is exchange of air, oxygen with the carbon dioxide. So there is profound hypoxemia. Here, in case of bronchitis, there is profound hypoxemia. So because of this profound, very severe hypoxemia, there will be vasoconstriction. The patient will have vasoconstriction, and that will lead to pulmonary hypertension. Okay, and this pulmonary hypertension will ultimately lead to cor pulmonale. So cor pulmonale, pulmonary hypertension, profound hypoxemia, it is more common in case of chronic bronchitis. Okay. Patients are generally obese, and because of cyanosis, they are called blue bloaters. Okay, so it is one end of the spectrum. And chest X-ray will show tram track appearance. Chest X-ray will show tram track appearance. Okay, so this tram track appearance, it is seen in other conditions also, like we have membranoproliferative glomerulonephritis, and also in case of chronic, in case of bronchiectasis. So tram track appearance, it is seen in case of bronchiectasis, in case of membranoproliferative glomerulonephritis, and also in case of chronic bronchitis. So 3 conditions generally. This is what I can think of right now. Okay. And emphysema, as I said, it affects, so bronchitis, it affects the terminal bronchioles, okay? And this emphysema, it affects airways distal to the terminal bronchioles, okay? So that is respiratory bronchioles, alveolar ducts, and alveoli. So the air exchange occurs distal to the terminal bronchioles in the respiratory bronchioles, okay? And wheezing occurs whenever there is involvement of these terminal bronchioles, okay? So since the airways are destroyed in case of chronic bronchitis, in case of chronic emphysema, respiratory bronchioles, alveolar ducts, and alveoli, they are destroyed, so the patient will have decreased surface area, so causing decreased DLC. Okay, the patient will have hyperinflated chest and decreased vascular markings and also dyspnea. Okay, so these are the description. So this is a comparison, as you can see, not very clear. So this is what we see on spirometry. Okay, this is the normal spirometry. Values are FEV, FVC is 4 and 5. Okay, so this is normal, as I said, ratio is 80%. These values you can remember. 4 liter, 5 liter, and the ratio is 80%. Okay, in obstructive it is decreased though. So these things you don't have to remember. Just remember the ratio will be less than 80%. Okay. So this is the picture which you will see in case of obstruction. Obstructive lung disease. Okay, clear? And this is in case of asthma. So COPD, it is irreversible. It is highly decreased. So asthma lies in between. Okay. So there will be increase in FEV1 when we give the bronchodilator. Okay, so as I said earlier, so it lies in between on spirometry. Okay, so this way the patient comes with dyspnea. We don't know what the patient has, so we will check the ratio. We will check the means by doing spirometry, and then we will give the patient bronchodilator. Okay, so that will differentiate. Okay, so this is the result which you will see, and the bronchodilator test which I showed earlier, that will show this kind of picture.